Thank you, Tarek. That was spectacular, those cases. So our next speaker is Dr. Sara Trucco. Dr. Trucco is Associate Professor of Pediatrics at the University of Pittsburgh. She's also co-director of the Cardiac Cath Lab and director for QI for Cath. And Sara will be talking about the role of heart catheterization.
Thank you, Jackie and Dr. De Silvas, for having me here today. All right. So in preparing for this talk, I had our research coordinator pull all of the cath patients that came to the lab with the diagnostic code of Epstein's anomaly. And if you look going back 10 years, for many years, we only had 5 to 7 patients come through the lab with this diagnosis. Subsequently, this is when Dr. De Silva arrived to Pittsburgh and the De Silva Center was founded, and we had an exponential growth of cath referrals with 40 cases coming through the cath lab in 2023. So what do we do in the cath lab for these patients? So we evaluate them both preoperatively and postoperatively in ages ranging from infancy to adulthood at various stages of palliation. And the majority of the cases are diagnostic with the main focus on pulmonary blood flow and pulmonary vascular resistance, though there are a series of interventional procedures that we can perform. It is incredibly rare to need to cath a newborn infant with Epstein's, but there were 2 cases over the last 10 years, 3 if we include one that had a dysplastic Epsteinoid-like valve. But the 2 cases I'll talk to you about today, one had anatomic pulmonary valve atresia, and what we could do in the cath lab is offer an alternative to a BTT shunt by providing a ductal stent. So if you look here at the first panel, that's what the ductus looks like. You see the massive cardiomegaly on the X-ray, and on the lateral panel, there is here the ductus, and this is what it looks like straightened up after the ductal stent was implanted. The functional pulmonary valve atresia case, this was a newborn that presented with extreme cyanosis, and we tried to do some manipulative maneuvers such as placing the patient on INO or reducing the PGE to try to promote forward pulmonary blood flow, but that did not work, and the patient was placed onto ECMO. And they came to the cath lab to assess the pulmonary pressures to try to determine why they were so cyanotic. And if you look here on ECMO, the saturations are normal, but that's the oxygenator doing their work. But the pressures were really normal in the lungs. So then we clamped the ECMO in order to see what the patient was doing on their own, and they became profoundly cyanotic, but the pressures remained normal. So pulmonary hypertension was not this baby's problem. What they needed was another source of pulmonary blood flow. When you look at this right atrial angiogram, you can see that there's very little blood making it to the RV or the pulmonary arteries. But we were able to cross the tricuspid valve and show that there's a nicely well-developed right ventricular outflow tract. The pulmonary valve opens and the pulmonary arteries were of good size. And this shows you what the RV inflow, or the atrialized portion of the right ventricle, looked like. So this patient ended up getting a BTT shunt, which allowed them to come off of ECMO and eventually have a cone. So in preoperative cath, what are the indications when you're outside of the neonatal period? We get patients referred of all sorts of ages. One of them is cyanosis, where we really want to know, why are they cyanotic? Is it due to low pulmonary blood flow, high pulmonary vascular resistance, or do they have an ASD with significant tricuspid regurgitation leading to right to left shunt? Additionally, if there's ventricular dysfunction, we want to evaluate the filling pressures for diastolic dysfunction, occasionally coronary angiography to look for a cause for systolic dysfunction. If we're unsure of the pulmonary pressures, evaluating their reactivity to oxygen and nitric oxide can be helpful in the postoperative management. And then we look for the associated anomalies that were mentioned in prior talks today. And then in our institution, we have been doing combined electrophysiology studies for patients with histories of arrhythmias. So they come to the cath lab, I do the diagnostic portion with some angiography and any required intervention, and then the electrophysiologist performs the EP study and ablation so that everything is performed under one anesthetic and one procedure. This is an example of a 3-year-old patient who had cyanosis and came to the lab prior to their cone procedure. If you look, the hemodynamics are relatively good, but the QP was quite low. So the pulmonary blood flow was quite low, the ratio of pulmonary to systemic blood flow was low, and the pulmonary vascular resistance calculation came out to be slightly elevated. So we did place the patient on nitric oxide, and although the QP didn't normalize completely, it did come up, as did the cardiac index. So the ratio did not improve, but the pulmonary vascular resistance fell to the normal range. So this was helpful in providing the patient nitric oxide following their cone procedure in the early perioperative management. This is another patient who was a lot older and came to us prior to the De Silva Center being founded. She had cyanosis with exercise. Her tricuspid valve regurgitation was relatively mild, but she had an atrial septal defect. Her hemodynamics were pretty normal, and so we decided to close her ASD, which was first test occluded balloon sized and then closed here with a Gore cardioform device. Nowadays, this is not what we would do. We would actually proceed with cone because there are benefits to remodeling the right ventricle long-term that can't be achieved in the cath lab. So actually, just a few weeks ago, we had a similar patient show up who was now in her late 40s. She had had her ASD closed decades prior with this device called a CardioSeal, which is no longer used. And she, over the course of her lifetime, developed severe TR, arrhythmias, RV dysfunction, and so she ended up coming and being palliated with a cone. So our practice now is, if you have a significant Epstein's, we would rather have you have a surgical ASD closure at the time of your cone procedure. My colleagues talked about how you see Epstein's on different imaging modalities earlier today, so this is what it looks like on cath. This is a catheter in the right ventricular outflow tract. You see it's very dilated. This is where the valve is sitting, and this is where it should be. So this gives us the tricuspid rotational angle that was nicely described by Dr. Silverman. This is a more mild version where the angle is much smaller. And here's a more severe version where the angle is quite wide, and you can see the attachments have been severely apically displaced and rotated out towards the outflow tract. Another finding that's seen on angiography is compression of the LV from the massive cardiomegaly. This is a patient that had a lot of RV dilation and led to some LV compression. This is a patient with much more significant tricuspid regurgitation. So although their LV dilation, I don't know why it won't play. There we go. Wasn't quite as bad. Their cardiac output was fairly low, probably due to the massive TR. So moving on to postoperative management, the indications for what we do really depends on what stage of palliation the patient is, and we'll go through each one. So in the post-BTT shunt, PDA stent, or STARNS patients, we're really evaluating their hemodynamics to see if a Glenn is necessary, are they a Glenn candidate? And then we also look at the RV pressure and RV angiograms in the STARNS patients. We look at PA anatomy that can be distorted following some of these palliations, and look at venous collaterals that can interfere with Glenn physiology. So this is a patient, international patient that came to us from Poland who had fairly good hemodynamics. It was now a toddler and had had a BT shunt not years, but many months before. And the only finding on the hemodynamics was mild RPA stenosis, which you see here. And when you look at the BTT shunt, it has become quite small over time, and it has tethered the pulmonary artery. So this was relatively mild, but it's still something you want to evaluate the PA anatomy prior to going to the operating room in any of these patients. This is a patient who had pulmonary atresia and came to the cath lab, and you can see that the RV pressure was about half systemic. The significance of this is a little unclear. The blood doesn't have anywhere to go. But when you look at the rest of this patient's hemodynamics, the pulmonary vein pressure was quite elevated. So aside from just LV compression, other left-sided structures that can be compressed, which are likely more important, are pulmonary vein compression that can lead to acquired stenosis. So this patient did have stenosis of the left-sided pulmonary veins, went on to have a cone with a BTT shunt takedown, and then had exploration and opening of this orifice. They didn't come back to our institution for several years, and I don't know why it won't play. Let me see if I click here. Good. And had developed neurotresia of the left-sided pulmonary veins. And through aggressive ballooning, stenting, redilation over the course of over a year, we were able to rehabilitate that pulmonary vein. But this is to tell people that if you do have pulmonary vein stenosis, you need to be vigilant in monitoring it for recurrence. For the Glenn patients, we evaluate their hemodynamics to see if they should go down a single ventricle route with a Fontan, a 1.5 with a cone and a Glenn, or can the Glenn be taken down and become a 2 ventricle circulation. Test occluding the ASD can be helpful in making this decision. And then in this physiology in particular, we need to evaluate for decompressing veins and aortopulmonary collaterals that can develop, especially in the right lung. And then look again at the pulmonary artery anatomy. So this is a patient who had a very low RV pressure despite having a Starnes, and it's because they had no pulmonary atresia. They had a nice, beautiful pulmonary outflow tract and good PAs, so they went on to have a cone with a Glenn takedown. This patient came to the cath lab because of cyanosis. They had a Glenn, but they had had their ASD closed with a device, and so in theory, their saturation should have been normal. Instead, they were satting in the 80s. So the question was posed, do they have pulmonary hypertension, pulmonary AV malformations? Why are they blue? So pulmonary angiography showed good PAs with normal transit time. We did a bubble study that showed no AVMs. And then this is the angiogram showing severe tricuspid valve regurgitation. But when we went on to take a picture in the innominate vein, they had developed large decompressing veins that drained to the pulmonary venous system. So this was coil occluded, the saturations improved, and they also went on to have a cone down the road. Following cone, the indications for cath are similar. Again, we look for the hemodynamics, if there's an ASD, whether it should be closed, if there's a Glenn, are there any decompressing vessels, looking at the pulmonary artery anatomy, and then this is the cohort where we occasionally are asked to look at the coronaries following a procedure. So this is a patient that came to the cath lab following cone because of cyanosis. You can see that they do have pulmonary vein desaturations in the 80s, and the systemic sat was in the 70s, relatively good pressures. And therefore, we put them on oxygen because the QPQS was only 0.5 to 1. So with oxygen, the pulmonary vein saturations came up nicely, but the QPQS did not change significantly, and neither did the systemic arterial saturation. So we decided this patient required more pulmonary blood flow. The RV was likely somewhat stiff and not providing enough forward flow. So this patient did go on to have a Glenn in the post-op cone procedure period. However, a few months later, with some remodeling in time, the patient was referred back to the cath lab with complaints of high pulsatility in the neck veins. And you can see now that when we take a picture here, there is pulsatility to the pulmonary arteries and washout here through the Glenn. So the patient ended up having a Glenn takedown and is now a 2 ventricle physiology with saturations in the high 90s. This is a patient who took a little longer to reequilibrate, so to speak, had some mild desaturation at baseline, but more so with exercise. We cathed them in order to see if we could close the ASD. And the first time they came to the cath lab, the cardiac index dropped significantly, the RA pressure rose dramatically, and so ASD closure was not performed. We gave them some more time, and then at the time of this cath, the cardiac index was maintained with closure, or with test occlusion, and therefore we were able to close it. Finally, with the last couple minutes, coronary angiography. So anytime a patient comes to the cath lab with Ebstein's prior to surgery, I always try to look at the coronary arteries either with an aortic root or selectives, depending on their age. And if you look here at this pre-op image, the coronaries are stretched over this large, large heart. And then imagine it being a balloon that gets deflated with the cone procedure, plication of the RA and the RV, and you still have the same coronary mass and coronary length. So they end up with this tortuous appearance. So once or twice we've had to cath patients for coronary concern following cone procedure, and what we found is this tortuosity, not any actual stenosis or obstruction, and this patient was able to come off of ECMO shortly thereafter. Finally, tricuspid valve replacement. So there are some Epstein's patients that come to us that have had a valve replacement either in a different era or at a different institution, and we are able to help these patients as well in the cath lab. So this is an adult patient who had significant arrhythmias and a lot of symptoms with inability to exercise. On the cath table, their gradient was about 8, which may not be that severe, but they were hypotensive under general anesthesia. So this was a real gradient. So we went on to dilate the valve and then implant a sapien valve in that position. And we were able to abolish the gradient, have no regurgitation, and this was with good hemodynamics. So in conclusion, Epstein's anomaly offers significant hemodynamic complexity, and the cath lab is able to evaluate and provide useful information both preoperatively and postoperatively. And we're also able to offer transcatheter therapies that can be life-saving and may allow for better outcomes. Thank you.